Good afternoon, everyone, and thank you for joining us today. We're going to give just a couple more minutes before we start our featured presentation, allowing time for everyone to join us. I see a couple more people coming in. We'll start right at the top of the hour. Thank you. Great, awesome. Thank you everyone for joining us today and welcome to the National Rural Health Executive Webinar Series. I am Cody Smith, Partnership Manager with NRHA Services. I will be serving as your moderator for today's presentation. To maintain a distraction-free webinar, all participants will remain on mute throughout the session to avoid any background noise. However, we do value your active participation and encourage you to ask any questions you may have during the presentation. You may do so by typing them into the question section of your go to webinar control panel, along with the name of the panelist you are wishing to address. Our team will collect all the questions during the discussion time, and we will look it over at the end of the presentation. I would also like to remind you that this event is being recorded, and you will receive an email with a link to the recording later today or tomorrow morning. All right. So today we have the privilege of hearing from Dr. Steve Barnett, President and CEO of McKinsey Health Systems, Rodney Buchanan, Hospital Administrator of Westfield Memorial Hospital, and Corey Scurlock, CEO and founder of Equum Medical. Our panel will be presenting on keeping care in the communities, telehealth as a lifeline for rural healthcare. Before we begin, I would like to extend our sincere thanks to our dedicated partner, Equum Medical. We are very grateful for your continued support and industry expertise, and all of that you offer us allows us to host conferences, educational webinars, and other events dedicated to improving rural healthcare. Your support is critical to our mission of advancing rural health initiatives. Not only do our partners share their knowledge and expertise with us, but they also play a significant role in supporting NRHA's efforts on Capitol Hill. Your advocacy and support are essential to our ability to influence policy and secure funding for rural healthcare programs. So once again, we thank Equum Medical for your ongoing support, and we are honored to have you as a partner in our mission. Without further ado, I'll turn it over to Corey for our featured presentation.
Thank you, Cody, and thank you to the audience for attending this. We really appreciate it. So, we're here to talk about keeping care in our communities and using telehealth really as a strategic tool for rural healthcare to try to retain and keep patients in their community and really optimize their care. And this is a subject that's really near and dear to my own heart. I myself am the product of a rural community. I grew up in a small town in Northeast Texas, and when I was a teenager, our hospital closed, largely due to financial constraints, and it caused families and patients to really drive 3 hours to get their care in a bigger metropolitan area. And so when I formed Equum as a physician, I really wanted to create a company that created equality for patients, regardless of their geography. And that's really where the title of Equum comes from. Equum is a Latin take on the word for equality, and every patient, in our opinion, deserves the same level of access, regardless of where they live. We also are vitally concerned about the rural healthcare market. We really want to serve that market. We think it's the backbone of our healthcare system, and it's vitally important that it be successful. So 4 things we're going to talk about today. Number 1, what role does technology play in telehealth? And we hope to convince you that while the technology is important, it's really the people and process around the technology that's just as important and vital to the success. Number 2, how do we use technology to keep care local? How do we reduce leakage rates? How do we keep patients in their community using telehealth as a strategic tool? Then number 3, what can a hybrid clinical organization look like as you start imparting telehealth into your organization and bringing it forward to your community? And then finally, we'll talk about telehealth in the future. And really, the future is telehealth, and telehealth equals health. And what's really important is that we clinically integrate this from the bedside to the website. I think we all agree that we're not going back to the pre-pandemic levels of telehealth. Telehealth is here to stay. It's now time to employ it and get the most value out of it. So I believe we have some survey questions next, Cody. So we'll start with the first one. What is your organization's current adoption of telehealth? Please select one of the following. No adoption, small investment for select use cases, a connected investment across multiple use cases, or telehealth adopted completely across your hospital. We'll give the audience just a few seconds to turn in their results.
Yeah, absolutely. I'm going to give it just a couple more seconds, Corey, and then I'll close so you can share the results.
Great.
Perfect.
All right. And so, not unexpectedly, 9% of the poll said no adoption. Telehealth's fairly ubiquitous at this point. 41% said a small investment for select use cases. 36% said connected across multiple use cases. And then a smaller percentage said 14% said telehealth's adopted completely across their hospital. And, this is exactly what we thought we would see, is that, when COVID came, many hospitals adopted single use cases of telehealth. And where we think there's real value is having a multi-service vendor of choice that can connect across multiple venues in your hospital and really derive value for you and be your strategic partner. So no surprise there with the first question. All right. Next question. What is your top challenge as it relates to the adoption of telehealth? Number 1, information and broader knowledge of its benefits. Number 2, funding. 3, clinical team buy-in. Or number 4, prioritization of other strategic initiatives.
Thank you, Corey. We'll just give it a couple more minutes for people to respond, and then I'll let you share the results.
Great.
Great. Thank you, everyone.
All right. Again, so reviewing the results. So the top challenge as it relates to the adoption of telehealth, 20% or 19% said information and broader knowledge of its benefits. 43% said funding. 19% said getting the clinical team to buy in, and then 19% also said strategic initiatives are important. And so again, right where we would expect to see, funding remains the number 1 reason why people don't adopt telehealth. And I think what we hope you hear out of this program is there is direct return on investment to your organization and return on quality that are real tangible and can be a huge success point for your organization and could lead you to adopt telehealth. So I think I'll turn it over to my friend Steve Barnett, and he'll take it from here.
Well, thank you, Corey. I appreciate it. Mackenzie's experience has really been a work in process for several years, and it really began with the implementation of the Affordable Care Act back in 2010. And since then, we've been modeling our mission around innovation and really changing delivery processes so that we are improving the health of the population we're serving, trying to be far more proactive than that traditional decades-old sickness model that we've always been involved in. So in an effort to try and organize around that new mission that's aligned with improving the health of the population, you can see that we've done a number of things. We've started an accountable care organization, co-founded it with a small group that in 2014 was launched, and today, one of the collaborative ACOs that really is just targeting rural organizations across the country is covering 350,000 Medicare lives in 22 states and Guam. And we started off with 8 organizations and now have 200 in this one collaborative ACO that are participating. I think that was a real opportunity to engage everyone in some of the vehicles that are embedded in the Affordable Care Act that allow us to move forward. We also became proactive in recognizing that substance abuse was on the rise, and we've continued to see that, even though it sounds as if there's been a crisis in the last few years. It's really been an ongoing problem that is decades old. So as many of us know, people will shop for drugs in your emergency department, and we created, with my medical director, over our ED hospitals program, an oxy-free program that allowed us to begin to at least deal with those folks that are showing up and really seeking to find drugs. Then we also know that we have a number of episodes of care. Those that there's a fair amount of evidence base that goes with how you manage these patients. And so from qualifying and becoming certified in trauma, one of the first organizations in the country of our size to be certified as heart attack ready or STEMI ready. And then we partnered with a large tertiary years ago, and this is where our technology journey began, and that was in developing a stroke network. And it's through those progressive changes and innovation, and then the adoption of technology, and how our clinicians here at McKenzie have been able to evolve with that technology, that I think it made it fairly easy when during COVID we had this experience, like so many across the country, where we may not be able to get patients out of our organization because some of those tertiary facilities we would normally transfer to were just too full and they couldn't take those patients on. And it's certainly within our scope to be able to manage many of the conditions that we found we were admitting during COVID. And it was during another webinar through one of the rural organizations that present that I listened to Corey talk about this model where he would offer intensivists to be able to enhance the services that you're providing and really be able to support both nursing as well as the emergency physicians that are in your organization. We had a conversation following that presentation, and then I think over the course of probably 4 or 5 months, that conversation evolved to the point of us launching last August with Equum and really seeing how we could take this to the next level. And our next level was not really trying to avoid transfers completely, but to make sure that we were keeping people local when we could. And I think, Corey, you spoke to that already as one of your objectives, particularly in rural America. People don't like driving long distances, and quite frankly, they love the care they get in their own little hospital because most people know everybody and it's very personal. So as we began to develop it, it's like any new program. It took several months of working together. Corey actually visited our location personally and talked to our ED and saw how we're laid out. I think that was important too, because you're able to communicate to your intensivists that we would be working with just what the place looks like and how they can interact. And I think we had a couple bumps leading up to launch with finding the right device. The one we did find is a fairly low budget device, and it does a great job. So we're very happy with what we've been able to use so far. And we've actually bought an additional device and put it into another space where we can do some more telemedicine over there. I think that our program is evolved, and it's increased in terms of the communication between physicians and nursing and the intensivists to the point that we're regularly seeing that conversation occurring now, and it's becoming almost more automatic as time goes on, that somebody will be dialing you guys up and getting an opinion, or maybe even asking for a consult. So I would tell you that, you know, this, along with all the other things that we've been doing, are clearly aligned and pointing in that direction of how do we continue to keep people local and improve health without ever compromising quality of care or patient safety. So that's Mackenzie's experience, and I think, you know, at this point I would ask that Rodney, I'm going to hand it off to you, and let's hear about what's going on in New York.
Thank you. Thanks, Steve. So I'm Rodney Buchanan. I'm the hospital administrator here at Westfield Memorial Hospital. And we're a very small rural hospital. As you can see, we only have 4 inpatient beds. We have a small ED that sees just under 10,000 a year. And our main service area is predominantly agricultural and rural. And the closest tertiary facilities are about an hour drive from our facility. So we do end up providing a critical stopgap for a lot of conditions, trauma, everything, you know, from pediatrics to geriatrics and medical to trauma. So it's important that that we're here, that we have this ability to offer these services here. You know, we have a basic menu of things that we do, you know, as you can see on the slide, from radiology testing to lab work, some outpatient ORs, anything that doesn't need to be admitted for OR stuff. So scopes and things like that. And then we're also like a mini tourist area with being along Lake Erie, and we have a lake in our county that's very popular with people. So we see a large swing in census from wintertime to summertime. And our population in the summertime can oftentimes climb by almost 30,000 people just by virtue of the summer. So we have to be kind of ready for any type of seasonal swings with that. And then we're part of the Allegheny Health Network. And so the Allegheny Health Network is a large network of hospitals that's based out of Pittsburgh, and their parent company is Highmark Health. You know, Highmark Health, as many know, is the insurance company side, and Allegheny Health Network is the hospital and the provider side. And so we are I think the smallest hospital within the Allegheny Health Network, and we're the only facility that they have in the state of New York. So understanding all that, you know, technology is definitely a significant part of our business here. By having technology, it does provide us access to what would be traditionally considered tertiary level care. You know, we're able to kind of bring that back into that rural setting. And much like Steve was talking about, we were able to keep more people here. You know, when I first started up here, our hospitalist group, and it's an old traditional model like you would have in the 80s, you know, where you have a PCP group in town, and they're also your hospitalist group that would admit patients and then go back to the office, see patients, come back in the evening, make sure everybody was okay, and then go home and then answer calls all night long. So that kind of limits your ability to admit a lot of acuity, because you have to balance their workload with the inpatient workload that's being admitted upstairs. So having this option of telehospitalist / teleintensivists that Equum does provide for us really kind of allowed us to step up our game a little bit, to take a little higher acuity type patients and be able to keep them here. You know, in addition to that, we also went to a telestroke model for the emergency department as well. Again, you know, like I said at the beginning, you know, very small facility that services quite a large area. You know, if you were to come with a stroke, you know, a lot of times it was just a rapid transfer to another facility, but at least now I can get a teleneurologist on, and we can go through the algorithms and TPA if we need to. And that's something that we can do that with our neurology group, and we have Equum to back us up from a critical care perspective, if so be it. Steve mentioned keeping patients longer in your emergency departments, and that is definitely something that we saw not only through the COVID pandemic, but we still continue to see today. Having a small emergency department with only one ER attending and no other providers, no other mid-level providers with them, they do get bogged down as just every other ED does. And if they have a critical patient that they're sitting on or waiting to be transferred, that can provide extra burden and resource in the ED. So Equum's been very good about being able to jump online, put the card in the room, and be able to, in conjunction with the ED attending, provide that critical care level service. And the nice thing about that model that we have with them is they're also fully integrated into our electronic health record as well. So they can document their consult. They have full visibility of the labs, radiology studies, images, notes that everyone's putting in, so they can see all that and work in conjunction with everybody. And I'll give you a couple examples. We've had 5 DKAs in our ER that actually went from emergency room visit managed by the ED attending and Equum, and was discharged from our emergency department because we were never able to get them to a tertiary facility. That's not something that we had traditionally done before, but we definitely were able to pull that type of thing off. Again, not ideal, but having that level of coverage and service was definitely needed. And I'm just finishing up my doctorate in nursing practice in my DNP. I actually graduate this weekend, and part of the DNP program is leveraging technology. This is actually one of the essentials of the degree, because I think and you'll see this as we all continue to talk and go through the presentation, it's tough in today's environment to not leverage this technology. And you see it across every service line, whether it be healthcare or other non-healthcare entities. So understanding that and seeing that's such a critical part of healthcare, for me as a DNP prepared individual looking at my organization, how do I then leverage this type of technology into my facility? And that was the other major attraction with the partnership with Equum. And really, it's a balance of in-person and virtual. And I will also say, tell people this is a marathon. It's not a sprint. This isn't something that you just decide one day, snap your fingers, and you got to make it happen. There's definitely a lot of strategic planning that goes into place, and you have to phase this in as you go through things. And we're still in that phase of growth right now, of reassessing and reevaluating and taking care of our patients. But at the end of the day, it's what keeps the rural hospitals alive, and it's really what brings that care in and allows you to keep your patients here. I think that's what I have to hand over. So I'm going to hand it back over to Corey for him to talk a little bit more about a few other things.
Okay. Thank you, Rodney, and thank you, Steve. And we are incredibly grateful for the partnership, and that's truly how we view the relationship. Is we want to be your partner, and we want to be joined on trying to create the outcomes that you think are important. And no single hospital has the same challenges, and trying to frame out those challenges and trying to help hospitals is really at the core of what we want to do. So, who is Equum Medical? We're an acute care telehealth services company. We are laser focused on inside the hospital space, whether that's ER, ICU, med surge, or even post-acute. If you think about our footprint, we go from California to New York, from Texas to the Canadian border. We take care of anything from large quaternary care, big academic medical centers, to community hospitals, to critical access hospitals, to post-acute facilities. And what I'm really happy to say is what started with one hospital 12 years ago now is over 45 hospitals. And in our 12-year history, we've never lost a client. And I'll talk a little bit about why that is, but we really pride ourselves on trying to deliver the very best results we can for our partners. If you think about the solutions we offer, we have a telecritical care, a tele-ICU, or tele high acuity, as you may hear it called. And that's really aimed at taking that into the ER, where, as Rodney and Steve both mentioned, a lot of the transfer decisions are made there. Certainly that's where the early stages of treatment begins as well. So we think that's a great place to put the program. Moving that into the hospital, where we can help round on the patient, shorten their length of stay, reduce their complication rates, hopefully. We also offer multi-specialty consults, which are cardiology, nephrology, pulmonary, ID, again, into the ER, into the hospital space, get the right patient, the right care at the right place at the right time, and really starting their treatment strategies early and hopefully allowing hospitals to retain patients. But if the patient shouldn't be retained or needs higher level of care, starting their care quickly so that when they transfer to a higher level facility, their lengths of stay are shortened and they can come back to their community more quickly. And then our virtual nursing solution, which is really a care standardization arm that helps mentor junior nurses and helps with the admission and discharge process as well. But it's one thing to have a physician who says, you know, I'd like to keep this patient, or I think you can keep this patient, I'll order this treatment. It's another thing to have the nursing staff comfortable with that treatment. And what we saw during COVID is there were so many junior nurses who didn't get the requisite experience that they would have prior to the pandemic. And so having a mentor or somebody they can reach out to help them with, you know, how do you mix this drug? How do you deliver this type of treatment can be a real lifesaver. And then finally, our virtual sitter program, which is a great way to watch patients for falls inside hospitals. Obviously, there's reductions in variable costs with sitters, but there's also a reduction in fall rates. And maybe most importantly, it allows the other staff to return to the bedside and to do what they need to do, which is really helps the frontline nursing staff and the doctors as well. And so, you know, I'm sure everyone's aware, but as a country, sentinel events rose 20% last year. CLABSIs and CAUDIs went up, not down, for the first time ever since we started measuring them. And it's not because as a healthcare system, we forgot how to treat them or don't know how to prevent them. It's really because with locums and transfers and agencies and the staffing crisis that we face mixed with high acuity patients, that it's just really hard to focus on these things. And so, you know, having a team that can help you drive these KPIs and drive these challenges, we think is very important. When we partner with hospitals, we obviously have a heavy flow component. We really want to work with hospitals to make sure, you know, the right patients getting the right care at the right time. We want to convert leakage to keepage, working with the ER teams, working with the nursing staff, really trying to unload them and help augment them is part of what we want to do. If you think of the three pillars of telehealth, there's people, process, and technology. We are technology agnostic. We think, you know, picking the right technology is really important. You know, having that technology have data behind it so you can run analytics and it's cost efficient for you. You can gauge the success of the program with it. That's really important, but we don't need you to rip out anything if you've already bought it. We are technology agnostic, and a big part of the reason why starts with the people and the people process technology equation. So our C-suite, we have over 200 years of acute care telehealth experience. Our average clinician has 6 years of telehealth experience. When we hire, we try to hire around the AAA. We want our clinicians to be able, meaning they're board certified, or if they have the requisite experience if they're a nurse. We want them to be available, and we measure response times. We want those to be very rapid. And then maybe most importantly, we want them to be amiable. With telehealth, you only get brief snippets of time with people. And in our opinion, you know, you need to have very good interpersonal skills to do that. And the real critical part of this that I think Steve and Rodney hit on is the change management aspect of healthcare. Very rarely when telehealth programs don't work is it that the technology failed. The technology typically will work if you set it up the right way. What makes telehealth programs not work is when the clinicians on both sides of that technology aren't aligned. They're not communicating well. They're not chasing the same KPIs. They don't understand their roles. So developing really strong change management techniques and really drilling those home and making sure your program's robust. And then once you've implemented it, going back and examining the program, are these the right KPIs? Are our workflows the right way? Are our communication patterns perfect? And chances are if somebody says, yeah, everything's great, then you know that just they haven't looked hard enough, because there's always little bumps in the road that you have to go back and visit. So that's a little bit about Equum, who we are. You know, Cody, I think I'm going to turn it back over to you at this point.
Yeah, absolutely. Thank you, Corey. And thank you, Rodney, Steve. Great presentation, awesome information. We really appreciate your time today. As we progress into this next phase of our discussion, I'd like to encourage all attendees to utilize the control panel to submit any of your questions. And please go ahead, and if you have one for a specific speaker, you can put the name on there as well. That works. However, before we commence to that section, I do want to do one last poll. If everybody could just take a minute to respond to this one. We'll get that launched here. All right. So select all that apply. The benefits of telehealth most important for your organization are reduce staff costs, increase access to specialists, keep more patients, reduce out-migration, community perception, and strategic planning for the future. I'll just give it a couple more minutes and I'll close this poll and we can share the results and then move on to our questions. I do have a couple questions coming in, so thank you, everybody. A couple more seconds for some more votes. Great, thank you, everyone. I'll share these. All right, I can't see those. Oh, here we go. Looks like, so I'm sorry, I guess I should put my glasses on. Looks like 44% of you say reduce staff costs, 81% increase access to specialists, 69% keep more patients, 44% community perception, and 56% strategic planning for the future. It's great. Thank you, everyone, for sharing. Corey, did you want to speak to that at all?
I think that was right on line with where we see the industry moving, and certainly all those answers are very, very appropriate. It was good to see, sort of the heart of this message is how can we keep patients local when appropriate, and how can we provide access to specialists to try, sort of bridge geographical challenges. So great to see those answers. Looking forward to the question set and ready to discuss that.
Yeah, absolutely. So the first question that have come in is, this is Steve, it's directed to you. Your program has been active for almost a year. Can you share on your experiences?
Well, sure. Be happy to. Thank you. I do want to first, though, congrats to Rodney for this outstanding achievement. Almost ready to graduate, and the best part is when you walk and you're done. That's a great experience and quite an accomplishment. Congratulations. Over the last year, I think, I had to laugh. I was making notes, Corey, as you were talking. And the one thing that both Rodney and I would say, and I know you have the same experience, every clinician does, you can do everything right, but if you don't have supportive nursing, you're dead in the water. And that is one thing that you're going to be working with the nursing staff more than ever. And I think that's the experience part that we've had over the last year, is how they have adopted this technology and they've begun to quasi develop relationships with some of the intensivists. So to the extent that Corey can make sure his organization has really got a group that, really understands each of the accounts and is kind of keeping an eye on them, the more familiarity we have, the more relationship building, the more trust that goes with all that. Those are all key components in rural America, as you know, that really add to the delivery of care and allow us to progress and continue to look for other opportunities.
Well, if I could just add to that a little bit, Cody, Steve, that was right on target. And part of what I think you made mention of this that we do is we provide a pod style staffing method, meaning we don't, we have over 100 clinicians in our company. We don't bring all 100 to really any hospital, particularly a rural hospital. One, because that would be not a good use of the hospital's resources in terms of credentialing and licensing. But number two, we want our clinicians to develop a strong relationship with the staff, and particularly the nurses. The nurses always get it faster than the physicians every time. And we want them to develop a relationship. We want them to understand the EMR. We want them to know, the different care patterns there, the protocols. And we think that's really invaluable. And you hit the nail on the head. It's really about developing clinical trust. And we think with that pod style mentality, you can really shorten that time. And that's where you start getting the change management that occurs.
Great, thank you so much. So Rodney, this one came in for you. What was your biggest challenge to ensure telehealth is benefiting your organization?
Yeah, no, great question. It was not technology, I can tell you that. So that actually performed very well, and we never really had an issue with that. Kind of a little bit similar to what Steve was saying. It was working with the nursing staff and the physician staff for full adoption. So on the surface, when we started introducing these concepts to the staff, they're like, yeah, that's fine. That sounds great, you know. But when it came down to actually doing it, it was a whole different ballgame. And I remember meeting with Corey and his team when they first came over, and we all agreed, you know, there was going to be some excitement about doing this until the day it started, and then it was going to be, you know, how does that look and how does it feel? Because it is different, you know, and you know, in a smaller facility, and Steve had touched upon this on his intro, you know, a lot of people know everybody, people are really comfortable with everyone. A lot of times the patients know the caregivers by first name because this is their healthcare has been here their whole lives. And so to introduce this, what I will consider and what some people even verbally said to me was this big brother concept of, oh, now I got this camera watching me and now I got to do this. And you know, there was some concerns from the physicians that Equum was going to be critiquing their medical decision making and, you know, making challenges to what they were ordering and stuff like that. We all knew, you know, and this is the art of leadership, right? So you have to learn how to guide your crew through that. And it's not a hard-nosed approach. It's not a, you know, you don't do that with a hammer and a chisel. You know, you got to talk to people and you got to be constantly rounding with people. And that was probably one of the biggest things that I ended up having to do. You know, I would check in, you know, daily with the ER, with the med surg area, you know, what's going on, what went well, what didn't go well, and then having that open line of communication with Equum and their boots on the ground team was critical, because things happen. I mean, we're humans, we're messy people, we make mistakes, we have ideas, we create rumors, whatever, and that's part of the leadership, is to try to smooth that stuff out. And so we were able to do that. Probably our biggest aha moment that got us over these challenges was at 2 a.m. and I kind of figured this was going to happen. It was a 2 a.m. patient up on med surg that went south, and rather quickly, from a cardiac perspective. The nursing staff was able to hit the button on the wall. They had an intensivist on within minutes. Orders were already in the record. I mean, they were faster than what the nursing staff could actually keep up with. They already had stuff implemented, and we were able to stabilize the patient, and actually ended up holding on to him for another 6 or 7 hours until the on-site hospitalist came in and then consulted with Equum and said, hey, what do you think we should do from a plan of care perspective? After that moment, the big challenge kind of smoothed out a little bit, you know, and that really resonated quite a bit with the staff, and that barrier kind of came down. And I think they realized that this is a partner in the care and not a dictator of the care. So and kind of getting through that process was probably the biggest challenge.
Great, thank you so much for sharing that. Steve, did you have anything you wanted to add?
You know, many of the things Rodney just stated, we've had similar experiences with, and I don't want to catch anyone off guard, but anecdotally, it's my understanding that if we, for example, were having Equum manage a patient that we might have on the floor, the level of monitoring and attention that patients get, depending on the level of care or acuity of care, I want to say we've discovered that it's probably even at a higher level in terms of attentiveness and catching problems than we have with the non-telemedicine approach or traditional approach to monitoring high acuity patients. And again, I don't remember the stats on it, but I do recall reading something along that line.
Awesome, great, thank you for sharing. Rodney, this question just came in. Can you speak to how telehealth is utilized for swing bed program, and if you have clinics that are currently using telehealth?
Sure, good question. So I don't have the swing beds here. We're actually looking at doing that, so I can't fully answer that question. But for the clinic pieces of this, we've also, since we've gone live with Equum, we're exploring and almost nearing completion of expanding out to telecardiology. where I'll have our cardiologist from Allegheny Health Network who will be able to televisit in to patients. That model right now is a live model where they're coming on site and doing that, but we've been able to brainstorm through this, and if I transition them to a telehealth model, I can actually add more days to their schedule because they have a full load in a hospital an hour away, and they're driving 2 days a week to my facility to see patients, to bring that care into the community. By switching to telehealth, I'll be able to actually increase that coverage. We've also done the same thing with endocrinology and rheumatology. You know, traditionally some harder services to get into a rural market. And again, we've used Allegheny Health Network physicians for that. It's mainly at the clinic level that doesn't really cross into the inpatient or ED side, you know, on the acute care side, but not important nonetheless. And so again, and this is kind of back to my comment of a marathon. I think that's just where this sparks the idea. You know, you take care of the acute immediate need, and from there ideas start to flow out of that, and you're able to actually add on to that menu of services that you're able to provide, and it reduces travel cost and it makes it easier for patients. And then we monitor that through patient satisfaction surveys, and you know, and we query them to see how they are satisfied with that visit. Monitor clinical outcomes to make sure that things aren't slipping, or you know, like A1C levels, for example, for endocrinology patients and things like that. So there's some metrics that we put around to monitoring those programs on the clinic side to make sure that they're still intact. So, but yeah, good question. Thank you.
Corey, did you have anything you wanted to add to that, or kind of any insight in how those things are working for you in other facilities?
I won't comment on the swing bed question because I'm not intimately familiar with that, but everything that Rodney and Steve just hit on is very important. And so, you know, making sure the clinicians, particularly the physicians at the bedside, understand that this is a program that really just helps augment the care they're already delivering. You know, we are not there to change care patterns. We're not there to try to change referral patterns as well. We're there to help accelerate their care that they would want delivered 24/7 and to help keep the patient in the hospital when appropriate. And so if anything, we're just an extra set of hands that from their standpoint, they could use 24/7. They can call 100 times, 1,000 times. It doesn't matter from our end. And so trying to make sure they understand we're their partner and really trying to help them is also a key to success.
Great, thank you. So now I have a question that probably is best for you to answer, Corey. Are your telehealth devices mobile? Do they move from room to room? If so, is it Wi-Fi, or do you plug it into port when you get to the patient care space?
Great question. And so, you know, it can be all the above, but what we would recommend is having mobile carts, because you can take them to the ER, you can shift them from bed to bed. It's much more cost efficient in general to do that model. They typically are Wi-Fi, although I have seen Ethernet ports used, but I think Wi-Fi is probably the way you want to go with that. And, you know, in terms of cost efficiency, we always want to get the best technology at the most cost efficient way for the hospitals. Nearly any of the carts from our standpoint are interchangeable. We can use nearly all of them. I think we can drive different metrics from them, and then we can be a partner in helping to select those if a hospital has a question around it.
Wonderful. Okay, have another question that came in. I believe this is for anyone. So how have you addressed the needs of interoperability, connectivity between the telehealth platform and other systems of care for the purpose of patient safety, care coordination, and care continuity? Interoperability helps you become technology agnostic, of course.
You may take a first stab at that one. So I'm going to just say our practice. Our practice is to document directly into your EMR, just like a physician or clinician would if they were in your hospital. We want you to view us like, you know, we were a member of your team. We just don't have to be standing there. So that becomes a very easy equation from our standpoint. There are, I'm going to say, clinical decision support systems that can help provide quality metrics that are important and might need interfaces. And those can be built, but that should not preclude the program from going live. If you have a burning platform and you really need to get the program up, those are all nice to have once the program's up, and then you can bring back data. But you know, the audiovisual platform, your EMR, and a clinician, are the things that we need to start immediately with your program. We need to build those relationships. We need to do the clinical decision support and the clinical process design with you while you're building all those interfaces. And so it's not a huge lift that's needed to get going, and it can be relatively rapidly.
Great, thank you. Another question, with all the technology on the market, how does a hospital make the right decision? Is there guidance to consider platforming for the future?
If I can go ahead and jump in here for just a moment. I know the device that we selected in part was keep it simple and keep it available, make it available, readily available, easy to access. We found that we've got a broad array age-wise of people who are required because of their role, either as nursing or an assistant or a physician, to activate this technology. So the easier we can make that, the better. We've found that the device we're using is very user-friendly, very easy to use, and it also allows us to take it in. So if we're rounding in the morning, we'll take Equum with us rounding. Yeah. So the patients can also visualize and interact with that provider who's remote, along with the provider who's here and the nursing staff. So, and in our case, whether it's an inpatient or a swing patient, if the swing patient needed some attention or there was something bubbling up there that we thought Equum might be able to play a role in later, which is not typically the case. But if there were, it doesn't matter what their admission status is. We just go ahead and use the provider, the intensivist, on those cases as well.
Where are the biggest benefits being realized? Can you share any program wins or feedback from your internal teams or patients or families?
I mean, for me at Westfield, our biggest wins have been the retention of patients in that extra level of care. And it's even recognized in our community, and we hear about it on our press gaining survey results. That it's almost been like a cover of, like a blanket, almost like a protective blanket that's been put over the hospital. Like, people understand now. When we first started talking about it, even in the community, in different community settings, even I got strange looks like, what are you talking about? Because we wanted people to be prepared. You're going to be seen by the local physician group who and you're also going to be seen by another provider who's also there to help out with decision making and stuff. And so that's probably been our biggest win and whatnot. And I found that involving the community was key as well, only because they know us so well. And so it would be an awful surprise to show up. This is your third admission over your lifetime, and now all of a sudden all this stuff's on the wall and there's this new person and stuff. So we did make a pretty good point to try to mitigate that by doing that.
And Cody, I would add on to Rodney's comments by simply stating that one of I think the biggest benefits that we've seen so far is that patients are actually have moved away from, well, I don't want that, or that big brother thing that you were talking about earlier. They are accepting technology and this way of bringing people closer who have skill sets that they might not normally be able to see locally, whether it's an inpatient or we're running a specialty clinic, as Rodney alluded to. The technology is becoming commonplace, and that's what, rural America, it's older, sicker, and poorer, and so it's nice that the sicker patients can be seen by people with great skill sets and that normally wouldn't be able to afford to come here because they're just not going to see the volume. But when you add it all together, now it makes a lot of sense, and people are beginning to realize that.
Absolutely, so true and helpful. Right now I have one question left, so I will encourage the audience, if you have any more questions, go ahead and get them in that go-to control panel. Take advantage of the time you have with these experts and all of their knowledge and things they have to share. Right now, I guess this question would be, what plans do you have to expand telehealth care from here?
I don't know if that's a Cody or
That was
Corey
an all
question or a Rodney question.
For me,
Yeah. I mean, we want to bring every specialty we can to rural America. And I think, Rodney may have some similar experiences, and I think this is where Equum has an opportunity to really expand. You got to have a partner that you trust that's going to be bringing services that you can depend on and not fall off because they were a startup and they tried this and then they couldn't bring together the specialists that we've identified we needed. Rodney said he has, rheumatology, cardiology, neurology, other specialties that, telemedicine's a good fit for. But over the years, as we've tried to work with tertiary units that we trust and do business with, they're trying to wrap their arms around these specialists who may be employed or independent. And that's like herding cats, I mean, it's really a challenge. And I can't tell you how many people we've had to run through here in terms of credentialing that never even probably provided service. So it's that throw stuff at the wall and see what sticks. And the difference is that today we need somebody that can really pull that off and do a good job. I think that's where the real opportunity, and that's where I need that level of consistency and dependability that comes from a company that can start bringing other specialists to the table.
I would just add to that. Thank you, Steve. I think that was a perfect answer, and we appreciate that. Telehealth, where it's going, I think, is exactly what you described. You want, instead of having 10 different partners for 10 different solutions, you want one partner who can bring you a variety of solutions, who's engaged strategically with you, who understands your environment and really wants to partner with you on driving outcomes, and that has the requisite experience to pull it off. And so, we always say we have 150 implementations of telehealth. Believe me, in the first 20, I made every mistake in the book, but through that experience level, we can effectively de-risk your implementation of telehealth, which is a big deal. If you don't get it right from the start, it's much harder to recover than if you just start and plan for an early win and succeed at that, and then hardwire that into your organization. Those typical change management steps really work, and having a partner that can help you with that's pretty invaluable when you're implementing this.
Absolutely.
And,
Awesome.
and I can just add just one more thing. Things that we're looking at, is obviously we're considering the infectious disease and telesitter stuff as well. We're just mulling that over right now. But one thing we did look at is under ED itself. After the implementation of Equum, we kind of got the idea when the ED gets overwhelmed, like I said before, it's one provider. And so sometimes that individual can get really behind. And so the ED attendings themselves, we have them now on a telehealth platform. So if one of them gets overwhelmed, they can call a friend, if you will, who then can remote in and start seeing patients, start implementing orders and watching for results and stuff, and kind of helping that on-site ED attending. And that all spawned out of this. So that's kind of we're already doing it, but it was a futuristic thing after we got started with Equum. So something else that spawned out of this whole process with us.
Wonderful. Thank you so much. That does wrap up our questions for today. Gentlemen, if you have closing remarks or anything else you'd like to share before we close out the day.
I would just like to say this has been a game changer for Westfield, and I think and I say Westfield specifically, but I think it's for all of rural America and even urban America. I mean, we're all facing the same shortages from a nursing and a physician and everything else. I mean, I don't believe healthcare is immune to that anymore. We always used to hear about the nursing shortage. Now it's just the healthcare shortage. So again, leveraging the technology to be able to still provide that level of care and quality is utmost importance. And I think that's our responsibilities as healthcare leaders to always be looking at that and what is the next step and what do I got to do, because being stagnant and doing nothing you'll end up getting run over by the system. And so you got to you have to really always be looking ahead. And I think that's our responsibility as leaders in the healthcare industry. But that's my opinion in closing comment.
Thank you.
Aside from what Rodney, I want to just reference a quick aha moment that we had probably 6 months ago when talking to one of our ED hospitalists, and he's trying to wrap his head around the idea that he can use this intensivist service anytime he wants, and just call them. You know, it doesn't matter. They'll be on the phone. They'll be on pop up before you know it, and there'll be people that you can bounce stuff off of, and if you want them, you know, to actually work up the patient, you can ask them to do that. And then I said, you can even do that at 2 a.m. when you're not ready to get out of bed, because they're always there. His eyebrows went up and go, that's got some real potential. You know? Yeah. So just kind of move beyond there.
Wonderful. Thank you. Thank you so much for sharing. Well, I would just like to say thank you all for being here today, sharing your information and insights. You guys are just such a pleasure to listen to, and we really appreciate your time. And Equum Medical, thank you for your partnership and everything you do to support us in our mission. As a reminder, I would just like to say, don't forget this will be coming out in a recording either later today or tomorrow morning. Have a great day, and we look forward to seeing you at our next event. Thank you, everyone.
All right.